I talk quite simple, so I've eliminated those slides which were overlapping. First of all, I would like to thank Dr. Amit sir and Dr. Rohit sir for giving me this opportunity to share my experience with Schwind. Like Dr. Natasha said, she has actually described quite a significant protocols and how Schwind machine works. So I'm just going to go a little into clinical details about surface ablation, because like we were seeing in the morning, there was a lot of talks about surface ablation and people had, okay.
Excellent talk by Natasha. I was almost feeling that she will be launching the next iPhone, the way she was presenting. And we will see, hopefully we'll see more such talks in IDOS, I think. So for now we end this session and we are starting the session on surface ablation. So I would like to thank our panelists, Dr. Shruti ma'am, Dr. Satish sir, Dr. Achal. For the next session, we would like to invite our esteemed panelists, Dr. Bharat Jain sir, Dr. Shruti, your presence is needed on the panel, and Dr. Trisha Agrawal, Dr. Harsh Mone sir, Dr. Bhatnagar sir, Dr. Arvind Bhatnagar sir is here from Ujjain, Dr. Safi Modiwala sir. Okay. So we have our panelists here. And with this, I would like to ask Dr. Aarti to resume her talk.
Thank you so much, Dr. Sumit. So going into clinical, like we were just seeing in the morning that a lot of talks about surface ablation, a lot of doubts were there. So we thought, why not cover this topic so that all your doubts are clear. Like we were discussing, PRK comes to rescue in certain scenarios. Usually in our clinical practice, we do see scans, like we were just discussing suspicious scans, whether we can see a little FFKC posterior elevation or superior inferior asymmetry, where the pachymetry is a little decentered, thin corneas. There are cases which have weaker biomechanics, or patients whose occupation, it demands, like defense, they want to join defense. So that's where you don't want to make a cut on the cornea. Or probably the patient is into active contact sports, so you want to avoid any kind of a cut on the cornea. And some patients are just skeptical about any and very apprehensive about any cut. So that's when trans-PRK or surface ablation comes to rescue. Because we know that surface ablation is, no suction, no cut, no flap procedure. It's also marketed as touchless LASIK nowadays. Definitely has wider application and certain scans where we avoid any lifting of the flap or making a lenticule. And it is definitely causing more biomechanical stability, and definitely there are lesser chances of ectasia. So there are these cases where surface ablation comes to role. So what is advanced surface ablation? We all know about conventional PRKs, where the first step we would probably remove the epithelium with the use of alcohol or mechanical debridement, or do a PTK, and then switch over to a PRK mode where we are doing a stromal ablation. So what is different in advanced surface ablation? It's a collective term used for transepithelial PRK plus a smart surf technology. So basically, what is a smart pulse technology? It is a flying spot excimer laser, usually used argon fluoride. It basically created this wow effect. That is, the short-term outcomes are very high. And that is the reason in traditional PRKs we would see, or we would get 6/6 or a wow factor after maybe 6 to 7 days of the procedure. Here, immediately the next day, the patient almost reads 98%. When I'm talking about 98%, this is actually, we have done it in our clinical practice, and we have seen that there's a huge difference between conventional PRK and advanced surface ablation. So advanced surface ablation, like we were just discussing, Dr. Sir was just mentioning, sir, so it does not create an island. In conventional PRKs, we would remove an epithelium around 8 to 8.5 mm and then do a PRK over it. So there was a crater which was created. Unlike in advanced surface ablation, the epithelial profiling as well as the stromal profiling is gradually from the center to the periphery. It is gradual, and that is the reason there is no island formation. And for the same reason, the epithelial remodelization which happens is much better and gives us a faster effect and gives us a wow effect. So I haven't had an experience with both the platform. I'm going to be discussing my experience on the Schwind MRS. Like Dr. Natasha said, it's a single step, more customizable, and it has faster healing and lesser haze. Very, very, very important is a good patient selection. I'm not going to go much in details because we all are aware that definitely patients with moderate to low myopia do better with surface ablation as compared to very high myopes. Main important is which are not an ideal candidates for surface ablation. Moderate to high myopic, astigmatism more than 3 diopter, I kind of avoid doing surface ablation for all the reasons we discussed in the morning. Hyperopes are not very good candidates for advanced surface ablation or for surface ablation. Moderate to severe dry eyes, because we know that they already have an compromised ocular surface, and over that, when we are expecting our epithelium to heal, it may not give us an adequate result. Patients with chronic allergies, chronic contact lens users are not good candidates for transepithelial PRK. And we know keloid tendency patients who have main important, like we were discussing, ultraviolet protective glasses are very, very important. So that is the reason the patients who have activity more outdoors should not be considered to do surface ablation. Mainly, we as doctors are very scared to do surface ablation for these reasons. We know that their patients usually complain of post-operative pain, there is delayed reepithelialization. Like we are saying, there are chances of regression, higher risk of infection because we are removing the epithelium, and the most dreaded is post-PRK haze. How the advanced surface ablation is different from the traditional PRK, is now what we are going to discuss. So first, coming to the first complication, that is post-operative pain. Why does the post-operative pain usually happen? It usually happens because the corneal nerves are exposed, inflammation is more, and that is the reason there is a neurogenic inflammation and the patient has pain. And how the advanced surface ablation has made it more simpler, it's because of the flying spot. Like we were discussing, this ablation pattern is in such a way that it reduces the thermal damage. Unlike the PRK where the spots were more thicker, so there was more thermal inflammation, more thermal damage which was caused. With the newer surface ablation, it is less. And of course, like with the use of more understanding of use of cold BCL, cold saline, the pain is drastically reduced. So I practice the same thing what Dr. Rohit sir has taught us, that we put a band-aid contact lens in the refrigerator one night before the surgery is planned, and just immediately once your surgery is about to get over, that's exactly when you will remove that contact lens before putting in the patient's eye. So using a cold saline and using cold band-aid contact lens really does wonder. And I have actually seen in my clinical practice that earlier, maybe 3 years before, when we were doing conventional PRKs, every evening I would get a call. Doctor, what have you done? I am regretting doing a refractive surgery. And that calls have almost reduced to 0.1%. The patients sometimes may complain that their eyes are they're not able to open their eyes, or they have constant watering, but never is the pain. Sir, this has really changed my practice.
One thing which is very important here is, what does the cold do? From a biological point of view, it increases the TRPM8 channels. Exactly the channel what Alcon is coming out as a new dry eye drug. It makes you feel that it's like taking a menthol tablet, and how do you feel in your mouth? That exact feeling you get with the cold. The one question which everybody asks is, there are a lot of people who don't believe that cold works, is as soon as you put it into the eye, it reaches the body temperature of 38 to 42 degrees. Then the cold disappears. So why should the cold last for a day or two? That's a very big question. The answer for this is, when you have a cut nerve endings, the nerve endings are exposed to noxious stimuli, like she's mentioned there. It's a naked nerves there. There's no oligodendrocytes like feeling with an epithelium. So all the responses, all those receptors are waiting to be actively firing. So the pain happens because these receptors are going into a overdrive. So minute you put cold, even though the cold disappears in 6 minutes or 7 minutes, it has created a channel in which the receptors have been told, or it has been altered, saying that now you have to act well and you have to work like you're increasing the thermoreceptor level. It's not the cold anymore. After 6 minutes, the cold aspect of contact lens is gone. What acts there is the receptor which assumes the role of making your eye cold when there is nothing cold in the contact lenses. That's biology of how it works, and that is paper which is published. So for all the people who were using it or believing it or non-believers, when people say, where does the cold happens after 6 minutes, please answer saying that after 6 minutes, the cold receptors will take over and that receptors can work on it. Exactly the same thing as using a drop and making those receptors to function. So the cold temperature does not exist after 6 minutes.
And also what I do in my clinical practice is I use a good opioid-based analgesic. And before the PRK, before the patient is scheduled for surgery, I give the first painkiller tablet then. So by the time the patient reaches home, that effect has already come and they don't experience. Basically, we want to give a wow factor to the patient because these are refractive patients, these are young patients. Their tolerance is less. They cannot wait for 2 to 3 days for, and the more we assure them, but they would not listen. So these are few clinical tips which can help you increase your practice or probably get more conversion into surface ablation. The second thing we saw is delayed reepithelialization. That is basically because of the mechanical damage. We are basically removing the epithelium, disturbing the epithelium basement membrane. And so that is the reason sometimes the patients can have a delayed epithelialization. But what is different in SmartSurf technology is that it basically creates a very smooth surface, residual corneal bed, because of which the epithelial regeneration, reepithelialization is very, very fast. And like our understanding is now much better. We use good steroids, surface steroids. Nowadays, we also give vitamin C supplements, vitamin D supplements, which add up to it. And definitely, sometimes, in my hand has not worked, sir. NSAIDs have not worked in my hand. I don't know, we back then, we used to use BCL soaked in NSAID.
That AccuVeil is not available.
Yeah, actually that was the main reason. The traditional AccuVeil which was available gave extremely good results, but now that it is not available, it was not giving that desired result. So I have absolutely stopped using NSAID dipped BCL. The most important is post-PRK haze, which most of us dread. So earlier with traditional broad beam lasers, where we used to not use mitomycin or steroids, I'm talking about way back in 1990, the incidence of haze was definitely higher. But with the now new techniques, with the use of mitomycin, with the use of steroid, with better excimer laser system, that PRK haze is significantly reduced, as close to less than 3%. But usually we don't even want those 3%, because these are refractive patients. So how we can do better to reduce this PRK haze is something which we discussed in the morning. That is, first of all, we should understand the pathophysiology of PRK haze, where I'm not going to go in detail. Sir very well, beautifully explained us the TGF-beta pathway. Basically, whenever there's an epithelial insult, there's reepithelialization. Most of the patients, or rather, first 3 months, they epithelialize properly, and there's absolutely no haze. Some of these keratocytes, they basically convert the myofibroblasts into gags, and they lay a disarrayed fibrillar collagen, which causes haze. And mainly it is problematic haze is the one which is a delayed haze. So that is something which we have to work on. Risk factor for PRK haze, we know that if we are treating more, if our spherical correction is more than 5, we can have haze. More than 3 diopter of astigmatism, hyperopic ablations, or more than 75 microns, there are chances of PRK haze. How do we avoid it? Definitely we take into account these factors. We also take into account UV exposure. So we tell the patients to use a good UV protective eyeglasses, not those 50, 60 rupees glasses which we give them immediately post-surgery. at least for good 3 to 4 weeks after the surgery. Definitely we have to take care of the vitamin D, the dry eyes, and if there is allergy, we need to first of all address them before we take them for surface ablation. So you want to add something?
One thing, just it's very important because there's so many PRK people here. You said one place where the epithelium, if he does not heal within the first 3 or 4 days, this patient is going to get very bad haze because it's going to secrete all those factors. In the past, there was nothing much we could do to make it faster, but the present indication for insulin drops is for faster epithelial haze, for even if you're doing cross-linking also. So it's not very difficult to make the insulin drops, unlike losartan. You take an Actrapid, 1 unit per ml. So if it's one of these drops, but use the not the sodium hyaluronate, it works very well with Optive because it's an osmo protection. Because what insulin does is it gives you tremendous amount of growth factors, and non-healing cornea, if it's taking a longer time, take an Actrapid, take 10 units into 10 units, 10 ml of it, shake it well 6 times a day, you heal within days. So never allow, this is a very important point, never allow your PRK patients to delay more than 5 days. 5 days is disastrous. So the best role for insulin drops, they got 100 other roles, but best place today is in it. And each one of you, I think after this, lots of government college doctors have started using it after we said, because it's very easy to do it. And you know, where the cornea is not healing, epithelium is not healing. So just, this is a very important
basically
take.
it is to prevent post
See,
PRK
you are
haze
seeing that
when
after
there are
third,
delayed epithelial.
absolutely. After the 3rd day, it's not healing. You're worried, why is it not healing? Still, there is a little. Just start on insulin drops.
So maybe that cutoff is 3 days and ahead.
No, insulin drops is a double-edged sword. You don't want too much growth factors. Too much growth factors will cause altered healing. You only use it when you see it's delayed healing. And this is something which all of you can practice in your clinic from day 1 tomorrow.
So maybe 3
So
days.
to
and
repeat
later.
it,
Hypermelose or
Opti the best.
basically osmoprotectant lubricating. So coming to post-PRK haze, prevention and management. For prevention, we know these are few things. I'm just going to quickly slide so that we can go ahead to the next talk. Pre-operative things that we can take care is definitely careful patient selection, check for dry eyes. If the patient ask them for hormonal therapy, especially it's very common nowadays, avoid such patients. If patients are on chronic contact lens users, treat them for dry eyes before we take them. Treat active allergies, note the occupation, very, very important, and the place where the patient resides. This is why I'm saying, and it's very important, like if suppose a patient comes from Australia, for example, where we know that the UV exposure is more, you would want to avoid surface ablation as compared to someone from place farther away from the equator. Intraoperatively, things that we can take care to avoid post-PRK haze is definitely achieve a smooth stromal bed, which is possible with the advanced surface procedures, either Streamlight or Trans-PRK. Use mitomycin. There is absolutely no indication where you should not use. I normally use 0.02% mitomycin for every diopter of spherical equivalent corrected. 10 seconds of mitomycin is soaked. Good irrigation to remove of that excess and to remove of the mitomycin. Cold band-aid contact lens and cold saline is very important, like we discussed, to take care of the thermal receptors. Post-operative, long-term use of corticosteroids because it helps to prevent inflammation. Good preservative-free lubricant. This I cannot, they say that you give for 6 weeks, 8 weeks. Why to give so much of lubricant? But it really does wonders when it comes to corneal health. So good preservative-free lubricant goes a long way. UV protective glasses, vitamin C and vitamin D supplements are actually incorporated in my regular routine of trans PRK. And a good regular follow-up, because at any time whenever you see the first sign of haze, you can either step up steroid or probably look for other options and to look for other newer drugs. Now, if suppose we have developed haze, now what else? So there are multiple gradings. There are slit lamp grading. There is grading based upon the, nowadays it's densitometry based anterior OCT, as well as the epithelial mapping based classification of haze, which we'll not go because it's very theoretical. This is a very good paper which actually very well summarizes the management of post-PRK haze. Early onset haze, we know we just have to step off steroid, and like we were discussing, prednisolone is very good in such cases because usually we are giving surface steroids, but when you are seeing a first sign of haze, shift to prednisolone, usually they resolve. The problematic is the late onset haze, which is after 3 months. Now, depending upon that, if the haze is superficial or deep, that's where your treatment will come. Superficial haze usually do very good with mechanical debridement if they have not been corrected with steroids. And deep haze, we may have to look for other options. So just coming very quickly to the role of newer treatment modalities, like we were discussing, cyclosporin plays a very, very good role when it comes to post-PRK haze. So as soon as you see this comes to a rescue, because it really works very well. Lifitegrast it does help to prevent as long-term inflammation, but already developed haze, it does not have any effect. So if you are suspecting that this patient will have inflammation, probably it has a role, but not where the haze is already developed. We were talking about losartan. So losartan is one wonder drug which is very easily available by Dr. Rohit sir. It does wonders because losartan helps to reverse the haze which is already caused. So if you have missed out and we've seen the patient has probably not come for follow-up and he directly comes with haze and reduced vision, losartan I have actually used in one of my patients and it does wonders. So I'll just quickly go to that case. 26-year-old male, not even female, male, very low myope, minus 2.5 with only 0.75 cylinder. I did PRK 1 year back. He was absolutely okay, not any positive history which would point or which would lead to post-PRK haze. But he presented to me 1 month, almost 2 months back with reduced vision. Left eye is significantly okay, although there is a slight haze there also. But if you can see right eye, there's significant post-PRK haze involving the entire pupillary area. Almost like we say grade 2 to 3. Again, I started with the same thing, steroid and lifitegrast, because that was easily available. But I saw that even after 15 days, even after 1 month of usage, the patient was not doing good. Then came to rescue Dr. Rohit sir. I called sir said I'll just send losartan topical drops, and 30 days of losartan, and if you can see the haze is significantly reduced. Patient is clinically seeing much better. Although, like sir said, that the entire effect comes only after 3 to 4 months of usage, and the patient is still on losartan eye drops. But I have practically seen the difference and significant improvement in haze quickly using losartan eye drops. So do you want to add something? This is the same patient Swami says sending me drops for. Undercorrection, overcorrection is completely overrated because with the newer machines, if you are doing surface ablation or you are doing flap-based, if you have done a good cycloplegic refraction, you will not end up in overcorrection or undercorrection. And like Dr. Natasha said, that Schwind has a 6D tracking platform, so the chances of error or the chances of undercorrection, overcorrection is almost minimal. So when we have taken care of all the things which are problematic to us, then why not switch to surface ablation, at least for the patients who are not absolute eligible for other refractive laser-based procedure. Thank you.
So just